Good afternoon, everyone. I'm here to present our study on corneal topographic changes before and after pterygium surgery using corneal tomography. Pterygium is a degenerative ocular surface disease characterized by a wing-shaped fibrovascular connective tissue overgrowth of conjunctival and limbal tissue onto the adjacent cornea. Pterygium causes flattening over the nasal and temporal paracentral area in the horizontal meridian. As pterygium causes optical irregularity, it can also induce corneal wavefront aberrations, which might not always cause visual impairment but can lead to significant subjective visual complaints such as glare and halos, even in patients with good best corrected visual acuity. Conventionally, we use keratometer to record the radius of curvature of the anterior corneal surface, but keratometer usually measures the fixed card length of 3 mm, which comes in the central optical zone, and it fails to identify changes in the peripheral cornea. So we have evaluated the preoperative and postoperative changes in corneal astigmatism using pentacam, a Scheimpflug imaging system for anterior segment analysis. Our aim was to study the corneal topographic changes before and after pterygium surgery using corneal tomography. Our primary objective was to assess the corneal astigmatic changes, and our secondary objective was to assess the higher order aberration in the central 6 mm of the cornea before and after pterygium surgery using pentacam tomographer. We included 85 patients in the age group between 22 to 55 years with primary nasal and primary temporal pterygium. We excluded patients with double pterygium, recurrent pterygium, those with previous history of corneal trauma, previous ocular surgery, corneal scarring, dry eye, and systemic autoimmune disease. We preoperatively measured the best corrected visual acuity for distant vision using a logMAR chart, and using pentacam we recorded the keratometric value in the flat meridian, steep meridian, mean keratometric value, keratometric astigmatism of the anterior corneal surface. And using pentacam we recorded the higher order aberration by root mean square in central 6 mm of the anterior corneal surface. Measuring the size of pterygium using calipers from limbus to apex was done intraoperatively. Pterygium excision with a limbal conjunctival autograft using fibrin glue was done. 6 weeks post-operatively, we followed up the patient. As seen, the prevalence of pterygium increases with the age, and the mean age was around 45 years. And the prevalence of pterygium in our study population was more in female patients. All our 85 patients had a primary nasal pterygium, which confirms the hypothesis that 90% of the pterygium occurs in the nasal conjunctiva because it receives a more solar ultraviolet radiation from the reflected nasal bone. We divided the group into two, the size, depending on the size of the pterygium. Group A included patients with 1 and 2 mm pterygium, and Group B included patients with 3 and 4 mm pterygium. And we compared the best corrected visual acuity, corneal astigmatism, and higher order aberration. We compared the mean preoperative and postoperative astigmatism difference between Group A and Group B, and Group A showed a significant decrease. The same way we did for the higher order aberration, and Group A showed a significant decrease. There was a statistically significant improvement in visual acuity and a decrease in corneal astigmatism before and after pterygium excision. And there was a statistically significant reduction in pre- and post-operative higher order aberration in the anterior corneal surface. Conclusion: successful pterygium excision can lead to improvement in corneal topographic changes induced by pterygium. It can lead to improvement but not complete reduction. Earlier excision of pterygium results in lesser residual postoperative corneal astigmatism and higher order aberration. Cataract or refractive surgery in a patient with pterygium should be planned after pterygium excision and stabilization of corneal topography. The corneal topographic analysis gives valuable information to patients with pterygium, so it should be included in the routine clinical evaluation. Thank you.
Doctor, you are not a ratified member, right?
No, sir, I am not a ratified.
So how did you do your follow-ups? At what period of time you have done this corneal topography?
After surgery, we'll call the patient after 1 week. But the study period was like after 6 weeks. We'll call after 6 weeks.
So after a patient completes 6 weeks after surgery, you are doing that?
We'll measure the post-operative.
So did you find any difference at 1 week? Then directly you called it 6 weeks, or in between also you had called it 4 weeks or so?
No, ma'am, directly at the 6 weeks.
Okay.
Patient follow-up was a difficult one, so we had only one follow-up at 6 weeks.
in your study?
Like we have evaluated the higher order aberration changes also. In certain patients, even if the pterygium is not involving the visual axis, the patients might have a significant visual complaints like a glare halo. So in those cases, instead of we can go for the corneal topographic analysis with this tomography to evaluate for that higher order aberration, and if it is significant, we can proceed with pterygium excision even if it is not causing reduction in best corrected visual acuity.